Now, as we finish off Chapter 14, we go into the spinal thalamic and spinal tracts. Just kind of a brief review. There's 31 pairs of spinal nerves in the spinal cord, C1 through C8. Remember, there's 7 cervical vertebrae, but there's actually 8 cervical nerves. T1 through T12, these are all peripheral nerves, L1 through L5, S1 through S5, and COCCYGEAL 1. All right, so again, the spinal cord ends at L1. Great quiz question, but it kind of has like these quad equina, which is like the horse's tail, that these peripheral nerves do come out. And probably the most famous one that you guys know is probably the sciatic nerve. And we'll talk a little bit more about the sciatic nerve, but that's a combination from L4, L5. So L5, S1 is probably a common numbness and tingling along the lateral side of the thigh, hip, and all the way to the big toe. That would be L4. On the outside would be L5, and numbness in the back would be S1. Those are some dermatomal patterns that you'll see. Now, ascending tracts, again, carry sensory information to the brain, whereas descending tracts carry motor information from the brain. So same as the acronym, sensory afferent, motor efferent. Many tracts cross the midline at decussation. That means it crosses. So injury to the right side may be due to a left tract, and that tract origin is contralateral to its destination. Thus, a right brain stroke impairs left side of the body's function. So a right CVA would cause left weakness, hemiparesis. But some tracts do not cross the midline, so the tract origin is ipsilateral. So let's take a look at these. Again, these major spinal tracts, the Brachial fasciculus, sensations of the spinal cord, spinal thalamic, sensations of light touch, tickle, temperature, pain, and pressure, spinal reticular does sensations of light touch, tickle, spinal reticular does sensation of pain from tissue injury, and the posterior spinal cerebellar does feedback from muscles such as proprioception. So if you're working somebody that has ankle rehab, you're essentially working the posterior spinal cerebellar tract. Okay. Now this is a little bit of review. We covered this a little bit earlier in the chapter, I think chapter 13, but I wanted to review these as we get into the brachial plexus. The lateral cortical spinal tract, the anterior cortical spinal tract, tectospinal tract does reflexive head turning in response to visual and auditory stimuli. Lateral reticulospinal does balance and posture, regulation, awareness of pain. Medial reticulospinal, lateral vestibulospinal, balance, posture. You're thinking, okay, what does all this mean? Well, if there's damage to the spinal cord, like let me give you an example. Remember Christopher Reeve, or a spinal cord injury, and you have damage to these major tracts, well then fine control of the limbs may be damaged. Balance and posture might be damaged. Control of head position might be damaged. Right, so you've seen somebody with a spinal cord injury where they have these injuries, and you're thinking, okay, now it makes sense why some of the symptoms manifest as they do. Okay, now here's the brachial fasciculus, cuneate fasciculus, ascending tracts, descending tracts. Okay, now again, if you look at these, so ascending are going to be all the sensory, right? So the brachial fasciculus, cuneate fasciculus, posterior spinal cerebellar tracts, anterior spinal cerebellar tracts. So these are all ascending to the brain. And then now descending, you're going to get the lateral cortical spinal tract, tectospinal tract, medial reticulospinal. So these are going to send information to the muscles. So again, it's a constant flow. It's like a highway, north and south. And north is going to the brain, south is coming back. Okay, so that's a good way for you to remember. Now, so ascending tracts, again, their sensory pathways contain first order, which detects stimuli to the spinal cord. So let's say you touch the hot stove, or you prick yourself with a pin. That's the first order. That's going to detect the stimuli from the nociceptors, and it's going to go to the spinal cord. The second order is the gateway, so it's going to go to the thalamus. And the third order is the cerebral cortex, so that's the level of consciousness. So depending on where the injury is, you can say it's a first order, second order, or third order injury. Now, 2 tracts ascend within each posterior funiculus to end in the medulla. So you have the brachial fasciculus that goes from the lower body, and the cuneate fasciculus that goes from the upper body. Now, This is the track that probably is the most important. This is probably the track that I'm going to quiz you on. So this is not a neuroanatomy class, so I don't need you to memorize all of the spinal thalamic and spinal reticular details or all the tracks, but the spinal thalamic track, probably the most important track, ascends in the anterior and lateral funiculi to end in the thalamus. This tract contains second-order neurons sensing pain, temperature, itching, tickling, light touch from the contralateral sensory neurons. So all that information that I put in red and there is a must know. There's some additional ascending tracts that do sensory, like the spinal reticular that does pain signals from injury, so you must know the spinal reticulatory tract. I also like the posterior spinal cerebellar tract, which does proprioception. So from a sports, athletics, you should probably know these three tracks. That's why I kind of put those out there for you. Again, just showing the decussation, which means it crosses in the medulla. Okay, and then here it crosses in the spinal cord. Now, how do you remember anatomy facts? Well, let's say immediately after class, you should probably review it. Then you should review it in 15 to 20 minutes. Then you should try to review it in 6 to 8 hours. And then really review it another 24 hours later. And really, this 4 repetition will guarantee it. What happens for most of you is you study the night before. So there's only so much Patel can do to help those. Those that are doing well, you can ask the students that are doing well. They spend a lot of time on it. I know with everyone has a different family situation, right? You have work, you have commitments. I understand that, but that is something that I cannot control. All I can control is how much time you put into our class, right? So I'm giving you the tools. Now it's up to you to do what you need to do to get a good grade. Here's a great YouTube for reviewing the spinal tracts. Watch that. Now, descending tracts basically are motor pathways that contain upper and lower motor neurons. Cortical spinal tracts carry signals for precise fine limb movements from the motor cortex, upper motor neurons. The lateral cortical spinal tract is a large pathway in the lateral funiculus. Anterior cortical spinal tract is a small pathway in the anterior funiculus. Okay. So remember, ascending does sensory and descending does motor. So additional descending tracts, the medial and lateral reticulospinal tracts, muscles of upper and lower limb and control balance and posture. The medial and lateral vestibulospinal tracts, balance from the inner ear. The tectospinal does reflexes, turning of the head in response to sight and sound. So 2 ascending tracts of the central nervous system. The general anatomy of nerves and ganglia. So a nerve is several axons wrapped by connective tissue. There's an endoneurium that wraps one nerve. There's a perineurium that wraps a fascicle of axons. And there's an epineurium that wraps the entire nerve. What are some upper motor neuron lesions? We've got Lou Gehrig's disease. You have primary lateral sclerosis, a traumatic brain injury, spinal cord injuries, multiple sclerosis, strokes, Huntington's disease. What are some symptoms of upper motor neuron? You could have weakness. You could have clonus, which is repeated spasms. You could have a Babinski reflex, which disappears at the age of 2. I'll show you what a Babinski is. You could have overactive reflexes. So if you suspect a upper motor neuron lesion with a patient, you can do the Babinski test. Basically, get a little sharp tool and just go up the foot. And normally your toes should curl down. But if you have an upper motor neuron lesion, the toes will curl up. Now, babies, try it. Before the age of 2, it'll curl up. That's normal because it hasn't really kicked in yet. But by the age of 2, around 3 or 4, their toes should start to curl down. Otherwise, we can suspect some kind of upper motor neuron delay or lesion. Okay, spinal nerves, proximal branches. You have the dorsal root ganglion. And I think I mentioned to you that shingles, if you ever had the chicken pox, shingles will try to lay dormant in there until a stressor will bring them out. So if you've never had chicken pox and you get in contact with somebody that has shingles, you'll get chicken pox. Okay, dorsal root ganglia is where they kind of reside. And then you have distal branches. You have the anterior rami. So a lot of these that exit, again, these are peripheral nerves, and you can get damage to these at any section. And and let's say you have bone spurs or you have inflammation, you can get an epidural, which is a corticosteroid shot right in here to bring some of the inflammation down. So here's the RAMI of the spinal nerves. Okay, spinal nerves. Here's that dorsal root ganglion. So now the nerve plexus receive fibers from anterior rami and give rise to the peripheral nerves. So the most commonly injured is the brachial plexus, cervical plexus in the neck, but the brachial plexus in the shoulder is commonly injured over at athletes, but just injuries in general. So really learning the brachial plexus is good, and being able to draw the brachial plexus is probably a good idea. The lumbar plexus is the low back, and then the sacral plexus. Now, try this. Make an OK sign, then a peace sign. OK sign, then a peace sign. OK sign, and a peace sign. Here's the cervical plexus, so C1, 2, 3, 4, and 5. Okay, so you can get damage to this playing football. Here's the brachial plexus. So the brachial plexus is very, very adept. This is something that you should know. It's made from C5, 6, 7, 8, and T1. And then, so the dorsal scapular nerve comes off there. The long thoracic nerve comes off there. These are the roots. Then you have the trunks. So imagine if you have a damage to the C5 root, well, everything would be affected, such as the musculocutaneous nerve. Okay? If you have damage to the trunk, then all this would be damaged, right? So really, or damage to the posterior cord. If you have damage to the posterior cord, then we know that the axillary nerve and the radial nerve would be damaged. So, and these injuries can happen anywhere. It could be a gunshot wound, a stab, a traction injury, a football injury. But the brachial plexus is probably one of the things that is injured the most in athletes and sometimes patients. Shoulder injuries, shoulder surgeries. So really knowing and spending time with the brachial plexus is probably a great idea. Knowing which branches come off of what. So a common question I could say is, if a patient comes in with damage to the posterior cord after sustaining a gunshot wound to the shoulder, what motions would he have difficulty doing? Then you'd be like, oh God. Well, you got to know what the axillary nerve does. Radial nerve, where's that? Deltoid, might have trouble just raising his shoulder, right? So something like to that extent. Again, there's one thing to just purely memorize anatomy, but then putting in the clinical setting at the end of the day is all what it's about. There's the lumbar plexus. There's that sciatic nerve, the famous sciatic nerve. Okay, and then there's the common fibular nerve, superficial nerve. Okay, so that's all coming from the lumbar plexus. And then you have the sacral plexus. These are the COCCYGEAL nerves. Okay. How do you damage these? Fall on your butt, snowboarding, skateboarding. So this is a great way of learning these, and these are dermatomes, area of skin innervated by a particular nerve. So a patient says, you know what, I can't feel anything on the side of my leg here. Then you know there might be damage to L5. Patient says, I can't feel anything on my thigh going across. That could be L2 or L3, right? Somebody says, oh, I can't feel anything in my thumb or first 3 fingers. That could be C7, right? So it gives us an idea. It's not the tell-all, but at least it gives us where to look in the neck, the back, et cetera, et cetera. So this is a good thing that you should probably learn for the clinic. Clinical perspectives, okay? So what does this all mean? You can have spinal shock, which is syndrome of paralysis and absence of reflexes. You can have neurogenic shock, which is a dangerous drop in blood pressure due to a lack of sympathetic nervous system activity. You could have paraplegia, which is paralysis of both lower limbs due to lesions from T1 to L1. That's paraplegia. Quadriplegia is paralysis of all 4 limbs due to lesions above C5. Okay. Hemiplegia, paralysis on one side of the body, usually due to a stroke or brain lesion. So make sure you know the definition of paraplegia, quadriplegia, and hemiplegia. Here's a spinal cord injury, what this would look like. So a C4 injury would be quadriplegia or tetraplegia, results in complete paralysis below the neck. A C6 injury results in partial paralysis of hands and arms as well as the lower body. A T6 injury would cause in paraplegia, results in paralysis below the chest. And an L1 injury would cause paraplegia, results in paralysis below the waist. Okay, so make sure you know these landmarks right here. All right, fix your eyes on 19 and go 1, 2, 3, 4, 5, 6, 7, 8, 9. This is a good concussion test, VOR test. Okay? The end.